these are really just the medical guidelines that we have currently. And I'd love during the question and answer session to take more specific questions on side effects and how we think about decision making. Just in the interest of time, it's not all in the organized slides. And then some cautionary tales about combinations that have happened recently that have suggested it to us that if we combine things without actually doing the studies, we may find that we're potentially doing more harm than good. So it's important to study things without just putting them together because they exist. So in a few years, we've come quite a long way. Prostate Cancer Foundation has been really intimately involved in all of this. But the guidelines, and Heather talked about guidelines too, the guidelines we use are usually NCCN guidelines, have changed a lot. This is from 2018, you can see here. And we have many different forms of general ADT plus abiraterone and docetaxel for hormone-sensitive metastatic disease. That's the M1 right there. And although the list looks shorter, it's actually just more organized. And we now see that we have ADT alone as really kind of a less preferred option here at the bottom. But docetaxel, abiraterone, apalutamide, enzalutamide, and radiation to the primary as options here for us for metastatic hormone-sensitive disease. So ARCHES, TITAN, and ENZAMET, which we'll review, and ARASENS and PEACE-1 are two other studies that are looking at combinations. There are others, but there is more information coming. So a lot to think about. Just in the last year, we've actually tried or had some opportunity to think about, we've had docetaxel and abiraterone combined with ADT in metastatic hormone-sensitive disease. Which one is better? I think many people, patients and physicians and caregivers, everyone asks. Some opportunity to think about that in the STAMPEDE trial. And this is a survival curve. I'm sure you don't look at these as often as I do. But when the lines overlap like that, that means that survival between two treatments, and each line represents a treatment, is pretty much the same. So what we see in this is that when we compared abiraterone to docetaxel, both with ADT in men with hormone-sensitive metastatic prostate cancer, there was no clear superiority of one over the other. They're pretty much the same, at least in terms of overall survival. But we as a field are still looking to see if there are genetic differences between people or other characteristics that could help us identify which one of these is better for an individual man, not just a population. But so exciting that we've had two phase 3 studies that have really given us actually new opportunities for treatment of metastatic hormone-sensitive prostate cancer. And that's the ENZAMET trial on the left and the TITAN trial on the right. And PCF has been integrally involved in these studies, as I should make sure to emphasize. Jonathan's got that. No, I'm just kidding. No. I'm going to go through a couple more, but we'll keep it brief. But that message of hope is really what I was hoping to convey. So I really appreciate you putting that in there. These are just two more studies. They're actually the studies, the ENZAMET and TITAN from the last page. With the line on top says that more people are alive. And the line on top in both of these drugs, enzalutamide on the left and apalutamide on the right. When we have ADT for men with metastatic hormone-sensitive prostate cancer, so it's still sensitive to that ADT therapy, and we add another drug, we help men live longer. So these are really important and just came out this year, both of them, so massively important. But I did want to add this cautionary tale. I have some of these because I want men to be very aware of what they're doing, not overtreat, not undertreat. It's sort of like the Goldilocks and the Three Bears. We just need to have the right one. When we combine things, too many things at a time, we may not be doing better. And what we just don't know. So in the ENZAMET trial, where they looked at ADT, so these are those injections that men get, or an orchiectomy, plus enzalutamide. If they also had docetaxel in that chemotherapy as well, there wasn't necessarily a clear benefit to adding the enzalutamide plus the docetaxel plus the injections. The docetaxel seemed to help actually everybody. On the top, we see these lines overlapping. The enzalutamide may or may not be adding. We just don't know yet. Enzalutamide alone on the bottom, the black line, clearly better than ADT alone. So whether 3 drugs is better than 2, we actually just don't know yet. And so at this point, we're generally recommending that ADT has to be added to something, but we're not usually recommending that it's added to chemo plus another pill. But that's always in the eye of the patient and the physician who's treating him. So these are all just generalities, but something to think about because the toxicities are more. The other thing I really like people to know about is that this is the STAMPEDE study out of the UK. Men diagnosed with this new hormone-sensitive metastatic prostate cancer, they looked at adding radiation of the prostate to this traditional injections plus for some men chemotherapy as well versus no radiation to the prostate. And they found that overall, and actually if you had lots of metastatic disease, there was no benefit to radiating the prostate. But if you had what they're calling low burden, or has also been called low volume, so a small amount of metastatic prostate cancer, and you radiate the prostate, the curves separate again, with the blue line showing benefit to radiation of the prostate in addition to all of the systemic therapy, the injections, plus potentially the chemotherapy. So radiating the prostate can be helpful. So there's more stuff, but moving on to metastatic castration-resistant disease, more advanced disease, I just wanted to pick out some highlights. This was an amazing phase 3 trial that was the first phase 3, and those are the kinds of trials that lead to drug approval. So this is a phase 3, end of the line, drug gets approved if it's helping kind of a study for men with the germline, or actually in this study it was from tissue, the somatic testing from tissue, the tumor tissue, abnormalities that Dr. Chang just talked about. So the mutations in BRCA2 or 1 or ATM, there's a list of things, and you can see all the list up here. Patients were identified as having those mutations in their tumors, and they had already had treatments for prostate cancer that was metastatic. They had had either abiraterone or enzalutamide and may have had chemotherapy as well. They were randomized to getting either abiraterone or enzalutamide, the one they had not had before, or getting olaparib, a PARP inhibitor that targets this DNA repair deficiency mutation that they had in their tumor. And they were followed to see if they did better. And again, these are the curves that we as medical oncologists, radiation oncologists, we love these things, urologists. When they separate, that says that one thing is better than another thing. The thing that's better is the thing up on the right, and that's the treatment with olaparib, a PARP inhibitor. We expect that olaparib is probably going to be approved for the treatment of prostate cancer, the metastatic castration-resistant setting, after progression on an AR-targeted agent like abiraterone or enzalutamide, and potentially docetaxel. But this showed clear benefit. And this very busy slide that you have in your packet just shows that there's still a lot to learn. Some mutations in this trial seem to benefit a lot more than others. We are still trying to figure that out, and that's across several studies that have been done with olaparib, that medication. But there are multiple PARP inhibitors also being investigated. So this is something that's coming down the pike that we're very excited about. The CARD study is a study, also a phase 4, so that's sort of a post-marketing, can we figure out how to do this better type of a study. Again, in the very advanced setting, what we found in this study is that patients who had had abiraterone, enzalutamide, again, those androgen receptor-directed therapies, hormonal type therapies, if they'd already had those and they got them again, they seemed to not benefit from getting that second treatment. If they got chemotherapy, cabazitaxel, because they'd already had chemo before in this trial, they seemed to benefit. So we're happy always when we see the separation of curves. We saw the separation of curves both for the way that their imaging looked and the way that they lived longer when they got actually chemotherapy rather than a second androgen receptor targeted agent. To say that more clearly, if you've already had abiraterone or you've already had enzalutamide, don't switch and use the other pill. It's not going to work. So whether you go to chemotherapy, whether you go to olaparib, if you have that mutation, do something different, change your mechanism or your approach. It's not going to work to do the same drug twice. So that was really, I think, helpful from this trial. This is fascinating. It's not a survival curve because I was trying to limit those, but this is imaging that shows that patients treated with lutetium, when they had these metastatic spots here in red, which you can all see very clearly, after lutetium had actually resolution of a lot of those spots. Now, these are some of the best images that they could pick, I'm certain, and it won an award of the year from the Nuclear Medicine Society, but this is what we're hoping for. This lutetium study vision is coming down the pike, and we hope that we'll get an approval here as well, because this is incredible, and hopefully it leads to people living longer. That's what the trial's looking for. Just very briefly to go over survivorship issues. Patients who are treated with hormonal therapy, those are the injections, ADT is the other word that I use commonly, have an increased risk, though slight in some cases, of heart disease, diabetes, thinning of the bones, and fractures, as well as potentially depression and possibly cognitive change. And PCF has actually worked over years to try to address all of these issues. There are guidelines around it. These are all in your packet, so I can let you read these. Things like multidisciplinary care, engaging primary care doctors and cardiologists and endocrinologists to follow cholesterol, blood pressure, and things like hemoglobin A1C, which tell you if you might be developing diabetes, are really important. Multidisciplinary teams are important to address survivorship issues in men with prostate cancer, and there are clear guidelines to help us do that. Bone health is also important. Calcium and vitamin D can be used to strengthen bones, and we can use scans called DEXA scans, or bone mineral density scans, to identify the men at highest risk of fracturing, because fractures are a problem. They could limit mobility, independence, and actually can increase the risk of death. So addressing bone health is critically important. And just really wanted to address too, depression happens when you have cancer sometimes, can happen more when you're on hormonal therapy. So being advocates for each other, identifying this, and getting people the treatment that can be so beneficial and helpful to them, approved agents for depression or counseling or just companionship and friendship, can be really, really important. And you as support group leaders, I think, can address that. I'm very interested also in cognitive change, things like the development of dementia. And so we actually have PCF-funded studies. This is only one of several that we're doing that are looking at the effects of exposure to different medicines on the way that men think and feel when they're on these drugs, and trying to identify, are there people who are more at risk for getting this kind of thing, like a dementia or a cognitive change that could impact them on a day-to-day basis. And then so briefly through cautionary tales, this is a very busy slide again, a clinical trial where we purposely tested to see whether radium, an approved medicine for metastatic castration-resistant disease, plus abiraterone, a pill that we use all the time, could work together synergistically to help men live longer and maybe have fewer fractures and fewer problems. And we actually, people had been combining these drugs just in clinical practice because you can. They're both approved and you could just give them together. The important thing here is that this box highlights, and you can see in your packet, that when we combined these agents, there were actually more fractures in the people who got the combination than the people who had only the abiraterone. We did not see that coming. We would never have expected it, and until we studied it, we didn't know. When we actually use bone health drugs that can strengthen bones, this signal goes away. So we can do something about it, but if we don't test it, we don't know necessarily that it's going to be safe in clinic. And so if your physician says, oh, I could try this, but I just don't know, tell the people in your groups, don't push the doc to combine things. If they don't know it's going to be helpful and it could possibly be harmful, just be careful. And this is a second study, really exciting study that looked at men with metastatic CRPC, combined enzalutamide and abiraterone. Maybe they'll work better if we use them together. And remember, I told you when the curves separate, it's actually one's better than the other. These curves are on top of each other. So there were more side effects in people who got abiraterone with enzalutamide together, and there was no benefit to getting both at once. So one at a time, don't do things off-label unless there's a good reason, or every person's an individual, so there may be a good reason, but we don't do that routinely. So in general, lots of stuff going on in advanced prostate cancer. Very, very exciting and a lot of hope. We're using things like genetic mutations to target and personalize medicines now, which is really, or treatment plans, which is really exciting. And we can't forget, I didn't have time to say it, but there's also things like pembrolizumab. So if someone has microsatellite instability, which you can pick up on some of these genetic tests, you'll find that too for tumor tissue, and you could potentially use checkpoint inhibitors as well. Lutetium's coming along the way, other radiopharmaceuticals. We always think about complications. We have to help people live well and not cause harm, and really combining therapies without having the evidence could leave us in a place where we're potentially doing harm without doing benefit. So we always just have to be cautious of that. But that's everything. Thank you for your time.